Hi dear students, today we will discuss about two obstructive airway diseases, COPD and asthma, which have got overlapping symptoms. And in asthma, cough is main symptom, while in COPD, productive cough is main symptom. And asthma is basically chronic inflammatory disease of medial and small airways, and which are very hypersensitive to certain environmental triggers. So there are attacks of wheezing and shortness of breath and chest tightness, which are usually reversible if the triggers they are removed, and it cannot be cured, but symptoms they can be controlled. While on the other hand, if we see in COPD, because of smoking and some other factors, there is mucus hypersecretion, ciliary dysfunction, and smooth muscle proliferation and airflow obstruction and hyperinflation. Ultimately, it leads to pulmonary hypertension and systemic effects, and it is largely irreversible. So, basic difference between asthma and COPD is reversibility. Asthma usually comes in attacks and is reversible, while COPD it is a constant sort of situation. Now, if we divide symptoms and signs of COPD and asthma, and we compare both of these things, we can see that asthma it can occur at any age, while COPD usually occur in middle age. And history of smoking is present usually in COPD, but not in asthma. Allergic history is not in COPD while it is common in asthma. Similarly, family history is also common in asthma. And then there are cardinal features like patient has got diurnal variations in case of asthma in the symptoms. Breathlessness is more at night and in early morning, while in COPD symptoms they are largely constant. And then after that, if we do pulmonary function tests, they are reversible in asthma, while in case of COPD they are not reversible. And airway hyperresponsiveness is not present in COPD while it is present in asthma. So these are few features which help us to differentiate between these two diseases, but sometimes it is very difficult to differentiate between these two. Now, what are the signs of COPD? Because of hyperinflation, normal chest, which is elliptical in shape, becomes barrel shaped in case of COPD. It means that anteroposterior diameter and transverse diameter of chest they becomes equal. Then there can be use of accessory muscles. Here in the picture you can see intercostal recession. Then after that, other accessory muscles patient can use like sternocleidomastoid and scalene muscles. They can be used. There can be tracheal tug in such patients, and then after that we can have cyanosis, central cyanosis, and JVP can be raised, and there can be pedal edema, which are the features of right heart failure. Then auscultation, we can find rhonchi, and these rhonchi actually shows prolonged expiration and obstruction. It becomes more during expiration and in patient of COPD. Then the investigations we do pulmonary function test, that is forced expiratory volume in first second FEV1 divided by FVC ratio, which is less than 0.7 in obstructive airway diseases. And then we give a bronchodilator therapy to these patients, and if patient responds to that bronchodilator therapy, means that if it is reversible airway obstruction, usually it is asthma, and if it is not reversible, then it is COPD. Then this is the categorization of the severity of COPD depending upon FEV1. You can see here that mild obstruction FEV1 is 100 to 70%. Then after that, it gradually it decreases. These are the nice guidelines of managing. In step 1, we give short-acting beta agonist. In step 2, we add low-dose steroid with SABA. In step 3, we add leukotriene receptor antagonist. And in step 4, we actually sandwich inhaled corticosteroid between SABA and LABA. So step 4 is sandwich basically of low-dose inhaled steroid between SABA and LABA plus minus leukotriene receptor antagonist. In step 5 and step 6, we actually give MARD therapy, which is maintenance and relieving therapy, which is the combination of long-acting beta agonist and inhaled corticosteroid, which in step 5 is of low-dose inhaled steroid, and in step 6 it is of moderate or medium inhaled corticosteroid. And in both of these step 5 and 6, with this MART, we can add leukotriene receptor antagonist. While in step 6 we do not give long-acting beta agonist and steroid as a part of MART therapy. We give it independently along with SABA, and along with this we can add leukotriene receptor antagonist. In step 7 we can add oral medication along with this therapy, like oral steroid or theophylline. Then the most important step in the management of COPD is smoking cessation. And after that, if COPD is of mild category, that is FEV1 is greater than 50%, then we can give only monotherapy, either with the long-acting beta agonist or long-acting antimuscarinic therapy, along with as required use of short-acting beta agonist. But if it is less than 50% FEV1 and it is moderate to severe COPD, we have to give two medicines together. Either we give LABA plus LAMA, or we give LABA plus inhaled steroid or LAMA plus inhaled steroid. Inhaled steroid is only given in that entity of COPD which show reversibility on giving bronchodilator therapy. Then after that, long-term oxygen therapy is the only therapy which can be given in the patient of COPD with right heart failure, hypoxemia and secondary polycythemia. Here oxygen is given 15 liters per 24 hours, and this is the only therapy which has shown mortality benefit in patients of COPD.